Hi everybody, and welcome to our module on the lymph nodes and spleen. Let's start by defining the concept of lymph. Lymph is the interstitial fluid that drains from tissues, and it drains into a system of channels called the lymphatic system. What it's going to do is circulate through the lymph nodes, and this is very important for activating the immune system in response to pathogens that may be present in the tissues where the lymph came from. Eventually, all the lymph in the body drains into the subclavian veins and then is returned to the venous system of the body. There are two types of so-called lymphoid organs. The first group is the primary lymphoid organs, and these are places where lymphocytes are formed. So these include the bone marrow and the thymus. These are the places that create the B and T cells. We then have what are called secondary lymphoid organs, and these are places where B and T cells can proliferate in response to infection. And this includes the lymph nodes and the spleen. It also includes the Peyer's patches in the GI tract and also the tonsils. So we're going to start by talking about the structure and function of lymph nodes, and this is an illustration of the lymph node structure. And you can basically think of a lymph node as having three layers. The first layer is called the cortex. That's this white area out here, and it contains these circular structures called follicles. We'll talk about what they do in a minute. The next innermost layer is the middle layer. That's this purple layer right here, and it's called the paracortex. And the paracortex is where the T cells sit. We'll also talk more about that. And then finally, the innermost layer is called the medulla. That's this red portion here, and it's got these cavities or sinuses right here. And the medulla has its own functions different from the paracortex and the cortex. There are multiple vessels that carry lymph into the lymph node, and they're called afferent lymph vessels. And then basically the lymph percolates through the three layers. So it will move through the cortex, the paracortex, and the medulla, and then it will finally exit through a single efferent lymph vessel. Each lymph node has a single efferent lymph vessel. And then, of course, there are arteries and veins which supply blood to the lymph node. Let's talk in a little more detail about how the lymph nodes work to activate the immune response. And in order to understand this, I want you to imagine that there is a site of infection in the tissues. Maybe it's in the skin or maybe it's in the lungs. One of the first things that's going to happen is that lymph is going to begin to drain from the site of infections towards the lymph nodes. In that lymph, there will be dendritic cells. Recall that dendritic cells are professional antigen-presenting cells, and they will have antigen on their surface from the site of infection. And they express MHC class 1 and class 2 and B7, and all the molecules you need in order to activate T cells. So the dendritic cells will enter the lymph carrying processed antigens on their surface. In addition, there will also be free antigens that get swept along with the lymph. So the dendritic cells with processed antigens and the free antigens will be in the lymph, leaving the site of infection heading toward the lymph nodes. The lymph will then enter the nodes, and there are many B and T cells waiting there looking to find their matching antigen. You can think of lymph nodes as places where B and T cells meet their unique antigens that can stimulate them. The dendritic cells will present antigen to T cells in the context of MHC. In addition, there are antigen-presenting cells present in the lymph node which can take up those free antigens and process it and present it to T cells. There are also B cells found in the lymph nodes that can react to antigen, and the result of this is that you will get generation of an adaptive immune response by way of funneling the antigens at the site of infection through a lymph node where B and T cells are waiting. Now that we understand how antigens travel from the sites of infection to the lymph nodes, let's talk about exactly what occurs inside the lymph node to generate the immune response. And we're going to do this by going through the three different layers and talk about what happens in each layer. So the first layer that the lymph encounters when it enters the lymph node is the cortex. That's this white layer on the outside right here. And all of the immune system action in the cortex is occurring in these structures called follicles. So the lymphoid follicles are found in the cortex of the lymph nodes, as I just said, and the main process that happens in the follicles is B cell activation. They are the site where B cells meet with their unique antigens and respond and begin secreting antibodies. The lymphoid follicles contain some special cells that help activate the B cells, and those are called follicular dendritic cells. Now these are different from the tissue dendritic cells that carry antigen from tissues to the lymph nodes. These cells are permanent residents of the lymph nodes, and they have special surface receptors that bind to complement antigen complexes. So they bind lots of different antigen complexes on their surface, and this makes it very easy for the B cells to cross-link and become activated. They are like pieces of Velcro that pick up lots of different antigens, and then the B cells can stick to the antigens and react. Now, a special note about the follicular dendritic cells, they are very important as a reservoir for HIV. Early after infection, large amounts of HIV particles are found in the follicular dendritic cells, and they're a major piece of the pathophysiology of HIV infection. There are two types of follicles in the cortex. Primary follicles are inactive. These contain follicular dendritic cells and B cells, but they are quiet. The secondary follicles are what you see during inflammation and infection. They're also called germinal centers, and these are sites of B cell growth and differentiation. This is where B cells may class switch and start secreting different types of antibodies. There are also nearby helper T cells in the paracortex, which we'll talk about in a minute, and these can bind antigens and stimulate more growth from the B cells. Here's a picture of a lymph node section under the microscope. This is a follicle right here, and you can see that it's got this white center, and that's a germinal center, indicating that this is a secondary follicle that's begun to respond to infection. There's another follicle over here that's also a secondary follicle. So back to our picture of the lymph node, we've talked about the cortex and the follicles, and now we're going to talk about the middle region of the lymph node, and that's called the paracortex. It's depicted by this purple section in here, and the paracortex is where the T cells are housed. So there are two important features of the paracortex that you need to be aware of. The first is that they contain T cells, which can be activated by dendritic cells that present antigen. The second important feature of the paracortex is that it contains special structures called high endothelial venules. These are special vascular structures that allow B and T cells to enter the nodes. It's easiest to understand this with a picture, so if you imagine a venule that comes after a capillary, normally the endothelium is composed of cells like this that overlap one another and they don't allow cells to exit. High endothelial venules, on the other hand, are a little bit different. These are venules that are found after the capillaries in the lymph nodes. You can also find them in Peyer's patches and in the tonsils. And they have an endothelium that is a little bit different. Their cells have spaces between them. And these are spaces that B cells and T cells can squeeze through in order to exit the bloodstream and enter the lymph nodes. And this is the mechanism by which B cells and T cells, which come from the bone marrow and the thymus, exit the bloodstream to localize into the lymph nodes throughout the body. Two other special things to be aware of about the paracortex: it can become engorged in an immune response. When patients have swollen nodes because they are infected, the paracortex is very large. And in addition, there are some children born with very rare T cell deficiency disorders where they don't have T cells. One of these is DeGeorge syndrome. And these children will have a very underdeveloped paracortex because obviously they don't have T cells to make up this portion of the lymph node. Back to our picture of the lymph node, we've talked about the cortex and the follicles, and now we've talked about the paracortex where the T cells live and where the high endothelial venules are. So now we're going to talk about the last section, the innermost section of the lymph node, and that's the medulla, which is this red section right here. And there are two portions of the medulla that each do different things. First, there are the cords, which are depicted by these red areas right here. And then those cords make little cavities, which are these sinuses right here. And there are different physiologic activities that occur in the cords and the sinuses. So the medullary sinuses are those cavities I showed you, and they contain macrophages, and they are constantly filtering the lymph, and they can phagocytose bacteria and viruses and other parasites or antigens that get into the medullary sinus. The medullary cords, on the other hand, are those tissues between the cavities, and they contain plasma cells that are secreting antibodies. Now let's switch gears and talk about the spleen, which is another secondary lymphoid organ. The spleen is located in the left upper quadrant. This is a picture of where you can find in the body right here on the screen. And the job of the spleen is to filter the blood. It has nothing to do with lymph. Some people erroneously think of the spleen as a large lymph node, but that's not the case. It's a different organ with a different structure. And in contrast to the lymph nodes, all the blood elements can enter the spleen. There are no high endothelial venules. There's no selective entry of T and B cells. Everything that's found in the blood can percolate through the spleen so that the spleen can attempt to filter the elements in the bloodstream. This is an illustration of the spleen. Blood enters through the splenic artery, and then the blood will percolate through two sections of the spleen. The first is this white section here, and that's called the white pulp. And then the blood will move through this red section here, which is called the red pulp, and eventually it will find its way back into the splenic vein and drain from the organ. There are three important structures in the white pulp that you need to know about. The first are the follicles, the second are the periarteriolar lymphocyte sheaths, or the PALs, and then you need to know about the marginal zone. And then in the red pulp, the most important structure are the sinusoids, and we'll talk about all these now. Let's talk in general about what the two different portions of the spleen, the white and red pulp, do. In the white pulp, the blood is exposed to B and T cells, which can be activated if antigens are present. And in addition, there are macrophages found in the white pulp that can perform phagocytosis. In the red pulp, blood gets filtered through the sinusoids, and these are very important for removing old red blood cells. And this is why the red pulp is red, because of all those red cells in the red pulp. In addition, many platelets are stored in the red pulp. About 30 or 40% of your platelets are stored at any point in time in the spleen. As I mentioned to you before, there are three important portions of the white pulp to know about. The first is the marginal zone. This contains macrophages, which remove debris. There are also some dendritic cells here that can process antigen. The follicles in the spleen are very similar to the follicles in lymph nodes. They contain B cells. And then the T cells in the spleen are found in those periarterial or lymphocyte sheaths. This is where T cells can respond to antigens present in the blood. So back to our drawing here, these circular structures are follicles. This is what contains the B cells. The periarterial or lymphocyte sheaths are these sheaths that surround the arteries, and that's what houses the T cells. And then the marginal zone here contains lots of macrophages and some other cells like dendritic cells. One of the most important structures in the red pulp of the spleen are the sinusoids. The red pulp is lined by vascular structures called sinusoids. These are essentially modified venous structures that will drain blood into veins, but they contain an open endothelium so that cells can pass in and out. The sinusoids are vessels like this, and they're separated by spaces called cords between them. And so blood can flow through the spleen, going into capillaries, then into the cords, and then into the sinusoids, and ultimately out into the venous system of the body. And importantly, the cords contain macrophages, and one of their major jobs is to filter and remove dying red blood cells from the circulation. So blood in the spleen is constantly going in and out of the sinusoids and the cords, and as this happens, macrophages in the cords are removing old red blood cells. The endothelial cells of the sinusoids are tall like this, with spaces in between them through which cells can pass. They have a thin basement membrane, often described as a barrel hoop membrane, but this is not enough to stop the passage of blood cells, so they can move in and out of the sinusoids and the cords, and in the cords they're exposed to those macrophages which filter dying red blood cells from the circulation. One of the most important things to know about the spleen is what happens when the spleen is absent or dysfunctional. And you should know that when you have splenic dysfunction, you are at increased risk for bloodstream infections from encapsulated organisms. Let's talk about why that is the case. Encapsulated bacteria, as you know, resist phagocytosis by virtue of the capsule they have which surrounds the organism. So the major way that the body clears these pathogens is by macrophage phagocytosis and also by complement. So these organisms need to be tagged with antibodies, usually IgG. That antibody can activate complement, which can directly kill the bacteria. In addition, the complement can create C3b, and both the presence of the antibody and the C3b will draw in macrophages, and these macrophages then can undergo phagocytosis and engulf the bacteria. So between the complement system and the macrophage, this is how these encapsulated bugs get removed from the body. When you have splenic dysfunction, you lose those marginal zone macrophages. This means you're going to lose phagocytosis. In addition, you lose the opsonization functions of antibodies. First of all, there will be less IgM and IgG antibodies against the capsules because you'll lose splenic B cells. There will be a loss of IgG opsonization for those macrophages. In addition, you will lose complement activity because the classic pathway of complement activation via antibodies is very important for activating complement against encapsulated bacteria. In addition to losing complement-mediated killing of these encapsulated bacteria, you will also lose C3b opsonization via the complement system. So for all of these reasons right here, you have great risk of bacterial infections by encapsulated bugs when you don't have a spleen. So let's talk about the bugs that cause infections in people who have splenic dysfunction. Strep pneumo is far and away the predominant pathogen that causes sepsis in these patients, and an infection with strep pneumo that gets into the bloodstream if you don't have a spleen is very deadly. More than half of patients will die from the infection. Other encapsulated organisms that commonly cause infections are H. influenza type B and Neisseria meningitidis. Some less common bacteria are strep pyogenes and E. coli and also salmonella. And then finally, recall that both malaria and babesia are protozoa that can infect red blood cells, and because the spleen is absent in these patients, it can't clear these infections very easily, and they can get an overwhelming infection with malaria or babesia. So why would someone have absence or a non-functional spleen? Well, one of the first reasons is if their spleen has been removed by a surgical procedure. And one of the most common reasons this is done is because of trauma. If trauma causes bleeding at the site of the spleen, the organ is often removed because you can survive without it. Another reason that people will sometimes electively have their spleen removed is idiopathic thrombocytopenic purpura. This is a condition where there's increased consumption of platelets and low platelet counts, and the spleen is a major site of phagocytosis of platelets, so by removing the spleen, you can sometimes increase the platelet count for these patients. And another reason is hereditary spherocytosis, so if you take the spleen out, there is less destruction of red blood cells and you will minimize the anemia. And then it's important to know that patients who have sickle cell anemia have a functional asplenia, so they have so many abnormal red cells that their spleen is often damaged from trying to consume and remove all those abnormal red cells, and as a result they are functionally asplenic and they are at risk for encapsulated bacterial infections. There are some characteristic peripheral blood smear findings in patients who have had a splenectomy that you should know. The first one is called the presence of Howell-Jolly bodies. Some red blood cells leave the marrow with nuclear remnants still present inside the cell, and normally these are cleared by the spleen, but they will appear in increased numbers in the peripheral blood if the spleen is not working. Target cells can also be seen in people who've had a splenectomy. They're also seen in liver disease and hemoglobin disorders. The basic principle of a target cell is that it occurs when there is too much surface area or membrane or too little volume. Essentially, you have increased membrane area to volume area. In liver disease, patients have too much surface area of the red blood cells. In hemoglobin disorders, patients have too little volume. The reason you get these post-splenectomy is because there's always a small number of them in the blood, but they're usually cleared by the spleen. But when your spleen isn't working, you will see increased numbers of these target cells. And then you will see thrombocytosis in patients who've had their spleen removed because the spleen is not removing and storing those platelets like it is supposed to do. This is a picture of a Howell-Jolly body on the left side of the screen here. You can see there's a red blood cell with some nuclear remnants inside. This is a picture of target cells. On the right side, you can see there are these circular target-like structures, these white structures, inside of the RBCs. And that concludes our module on lymph nodes and spleen.